Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your co-host, Dr. Brittany Scruggs.
And I'm your co-host, Dr. Eric Bothan. We are here to bring you the latest and greatest in ophthalmology, medicine, and more.
Today we are joined by Dr. Edward Cordes, the chair of Lions KidSight USA Foundation. Tune in to appreciate why Lions clubs and eye care providers across the country value this important vision screening program.
Dr. Edward Cordes is an optometrist who's dedicated much of his life to vision screening through Lions Clubs International. Before his retirement, Dr. Cordes served as an optometrist in Corning, New York. His leadership roles included serving on the State University of New York College of Optometry Council and the Children's Vision Coalition. Along with clinical practice, Dr. Cordes has lived a life of service ranging from military, optometric professional organizations, and community service. His capstone organization since 1976 has been Lions Clubs International. Service roles include Board of Director of the International Association of Lions Clubs, co-founder of Lions Arthur P. Darling Low Vision Center, and the chair of Lions KidSight USA Foundation. In addition, he's been recognized for his service to the association. He has received numerous awards, including International Presence Certificates of Appreciation, Leadership Awards, and medals, including the Ambassador of Goodwill's Award, the highest honor granted by the association to its members. Today, we have the opportunity to hear about a remarkable career of service and a special program for kids. Good. Welcome to the podcast, Dr. Cordes.
Thank you very much. I'm very pleased to be here. I've been looking forward to this, and I really appreciate the invitation and the ability to share Lions KidSight USA and the work that we're doing to help children in need.
I want to hear a little bit about your history because I know you from my Pediatric Ophthalmology Society meeting and learning about KidSight. But let's go back for listeners that don't know you as well as I do and share your journey of becoming an optometrist. What's your career focus been and why vision screening?
Well, that actually goes back to some of my military experience. When I first went to college right after high school, I really didn't have a whole lot of direction. So after 2 years of college, I left and joined the Navy, became a hospital corpsman or a medic. During that time, I met some people who were in optometry, and I learned about eye care. I learned about the eye, and I was kind of fascinated with that. So I kind of set my goal that when I got out of the service, I would go back to school and become an optometrist. But more importantly, I served a tour in Vietnam, and while I was in Vietnam, I did not have a combat position, but while I was in Vietnam, we ran a dispensary in a little town called Tu Lai. And while we were there, part of our job was to go out into the villages. We would get two of us in a Jeep and a local helper, usually a teenager or someone like that. And we'd go out into the villages, a half hour, 45 minutes, an hour away from base, and treat civilians. Well, I was 22 years old, and you drive into some town, and there's 200 people, 300 people waiting for this 22-year-old medic to be their only health care. And I realized that the rest of the world was really not like middle-class America where I grew up. So that made a big impression on me. And fast forward to when I finished my undergraduate, I went to Pennsylvania College of Optometry in Philadelphia, where they had a program sending 2 juniors and 18 seniors and a faculty advisor to Haiti on a vision care mission. I was fortunate enough to be one of the juniors to be chosen and became chairman of it my senior year. And we went to Haiti in 76 and 77 and did eye care for people who had no access to eye care whatsoever. Well, the tie-in is that Lions in the Philadelphia area, Lions clubs in the Philadelphia area collected used eyeglasses for us and gave us some money to go ahead and conduct this project. And the Lions finally said, you know, Ed, we've been helping you for a couple of years now, supporting your project. Why don't you help us and become a member? And so I did, because I saw firsthand what Lions can do, not just locally in the Philadelphia community, but also their international outreach, because they helped us do that mission. And that's how I got into Lions Clubs International.
So you have served in various roles in international organizations, including the Association of Lions Clubs. You've been the director, correct? The director of international leadership. Is that accurate to say?
Yeah, the Lions Club leadership structure has vice presidents and a president, and then a 32-member board of directors. I was elected to be one of the U.S. representatives on that board. At the time, there were 15 of us on the 32-member board. So I was one of the U.S. directors that served a 2-year term from 96 to 98. And then I was fortunate enough to be appointed by the next president, 98, 99, to serve as a non-voting advisor member to the board. So I served 3 years on the international board.
I will admit it's special to highlight you and your role in Lions on this episode. For those of you that are interested in Lions International and want to learn more, even on our podcast, we had recently recorded 2 last year, released last June, with past international president Brian Sheehan. So we love having you here. We really celebrated that episode. And as a plug, our department, our optometrists and ophthalmologists here at Mayo are its own Lions Club. So we have we're the Lions Ambassadors Club in Rochester, Minnesota, and I encourage programs or optometric or ophthalmology groups to consider similar programs in your state. But certainly appreciate your leadership as Dr. Scruggs is highlighting some of the roles you've served.
Well, thank you. I'm so glad to hear that you have a Lions Club associated with your group. I did not know that, and I am just thrilled to hear that.
It's been a rewarding journey.
Yeah, Dr. Bothan is the president of our club, and I'm the secretary.
Secretary is the hardest job in the club, as anyone.
That's why we put the best person in that role.
I'm not going to contest that. So one thing that I learned from Dr. Bothan is that you have worked with your wife pretty closely professionally. She was a prior optician. And so we wanted to know a little bit about that relationship, and specifically you both co-founded a low vision center in New York. Can you share that story with us?
Sure. Gail and I met when we were at Ohio State way back in 1966. And we've been together ever since. We got married in 68. We were married when I was overseas, and have been doing everything together ever since. When I graduated and started our practice in Corning, New York, Gail started off as a business manager and then became a licensed optician, and we ran that practice for 25 years before we sold it to Guthrie Medical Group, and then we both went on their staff for 15 years before we retired. The Arthur P. Darling Low Vision Center is an interesting story because the doctor, Arthur P. Darling, was a general practitioner in Corning and began to lose his vision due to macular degeneration. And this was back in the late 80s, early 90s. Well, Dr. Darling then went on, he closed his private practice and went on staff for Corning Incorporated, which was the big is still the big corporation in town. But at the time, there were no low vision services or even retina services in Corning. There are now, but back then there weren't. And he was rather frustrated that he had to drive the 5 hours to New York City or take the Corning Incorporated plane to New York City to get low vision services. He knew that Lions Clubs were very much involved in helping the blind and visually impaired and people who needed help with eye care. So he came to us and asked what we could do. Gail and I and a pharmacist who was also a Lion got together, and we said that we could start a low vision center. So we put together a fundraising campaign, and we raised about $30,000 locally. And then we went to Lions International Foundation, the big foundation associated with our association, and asked for a matching grant. So and we got that grant. So between the two, we had $60,000, and we started the Arthur P. Darling, named after Dr. Darling, Low Vision Center in Corning. We're associated with the Southern Tier Association for the Visually Impaired. My wife happens to be on their board for the last 30 years or so, and created this Low Vision Center with volunteer docs coming in and treating patients for low vision services upon the referral of their personal eye care practitioner. And it's been
Wonderful.
ongoing ever since, and we're very proud of that.
Wonderful. Yeah, we've certainly have other podcasts too about low vision. We just appreciate that mission and spirit that you have. I have to ask one question, and just on a personal side. Sometimes when you lead things with your spouse, there can be rich blessings from that, but also challenges. And the more I've gotten to know you, the more I appreciate how the two of you are really a team in international service, in Lions efforts, the KidSight, which we're going to talk about in a minute, because that's really a big program for you guys in this low vision side. So do you have any advice for those of us with spouses, whether professionally or in service, share a little bit about the blessing of doing it with a spouse or significant other, and or what advice you have to make sure you end projects in unity?
Well, the blessing is that we do everything together, and we're hardly ever apart. Quite frankly, the only time we've been apart for any length of time is when I was in Vietnam. The rest of the time, we do everything together. In the office, when we had our private practice, we had a pretty good division of responsibility. Gail was responsible for everything outside the exam room. She was, as a licensed optician, she was responsible for all the optometric materials for our employees, the administration of the office, and so on. We would consult together on the business decisions, but her responsibility was to basically run the practice like a practice manager, and my responsibility was patient care and examinations and all of that equipment and all those decisions, and it worked quite well. When we moved to Guthrie, while we still worked in the same department, she was in the optica department and I was in the eye care department for clinical services, and so we were divided then, but we still worked together as a team. I think the challenges are that you really need to be able to turn things off. You really need to be able to go home and have a real life and not keep dwelling on the things that happen during the day. And a lot of our vacations, where some of our colleagues would take vacations only in association with the professional societies and so on, we developed interests outside of our profession that gave us another dimension to our life, and I think we were pretty successful in that. And another thing, Gail just handed me a note. We don't have any children, so I said we work together as a team.
I love that.
We don't have any children, so that allowed us to focus a lot on our Lions life and the other things that we do, and that's just in addition to our profession.
Well, it's a lovely partnership. For those of you that are curious about photography, there's an eCordisphotography.com website. You can go check out and see a lot of remarkable photos from the two of them around the world. All right, let's talk about KidSight.
Yeah, let's talk about it. So in 2014, you created Lions KidSight USA Foundation. Is that correct?
That's mostly correct.
Mostly correct. Okay.
Yeah, if I can give some background, Lions.
Yeah, that'd be great. We want to know about the program, the logistics, the public health need, and what really led you to start this program.
Lions have been involved in vision care, and help for the blind since 1925, when Helen Keller challenged us to become Knights of the Blind in the crusade against darkness. So throughout the years, various vision screening, vision services occurred, but not, they're very loosely organized, not very organized, and didn't have very well thought out best practices and standards of care. In the late 1990s, the first, I don't know if you remember the MTI photo screener that came out that used Polaroid film and took binocular pictures of the reflections that come out of the eye when you take a flash picture. And a professional would analyze those pictures and decide whether there was some refractive error. Lions got involved in that, and there were a lot of vision screening programs going on around the country. When the electronic photo screeners started coming out, even more vision screening was done around the country. Well, Lions International was looking for a way to unify the clubs in a way that would give a single project that the public could identify with as Lions doing. So instead of the public thinking, well, the Lions collected used eyeglasses, or the Lions do pancake brunches or chicken barbecues, we were looking for something to be more meaningful, more impactful, but also unify the Lions. So I was approached by the past presidents of the association to head up a program that would create that unification and also create some best practices and so on. And that was in March, I believe, of 2014. We've never done this before, and I'll never forget, I was asked by past President Joe Preston from Arizona to do this job. And I said, Joe, we're good friends. I'm very happy to do it. What do you want me to do? And he said, we've never done this before. You have a clean slate. Keep me informed, which I did, obviously. And so that's how KidSight got started. I traveled around the country for 6 or 7 months, visiting some of the major programs that were very successful, picking their brain on what the best practices are. I studied a lot of professional material on standards of care, referral criteria, and so follow-ups, and so on and so on. And we put together Lions KidSight USA originally, and developed the vision screening program that acts as the foundation for what we're doing today. And I think the idea was to, and the result is to unify everyone under one umbrella, be sure we promulgate best practices and best standards of care, and then be sure that we have good follow-up for the patients that we refer. So that's how it got started. I should say that now we're phasing out of KidSight USA because we've expanded internationally quite a bit. So while KidSight USA Foundation still exists, its lifespan is limited. We're now creating Lions KidSight, just Lions KidSight, and we've started programs in many countries around the world. And I just got back from India. Gail and I just got back from India, where we did major vision screening and helped them start their program.
You shared with me before the call, how many children did you screen in your trip to India?
Well, there were 8 screeners using electronic screeners and 6 docs, 3 docs from India and 3 docs from the US. The screeners did 11,200 and some odd patients in 5 days. And then about 2,000 of those needed to see us docs. And we saw all of them, and about 80% of them needed to have eyeglasses. Now, I have to say, we provided strictly eyeglass care. We found some keratoconus, we found some cataracts, we found some other things that were referred to the local Lions Eye Hospital for further care. But it wasn't the kind of comprehensive eye exam that we do here in the United States, because it just wasn't the venue to do it. Our job was to get as many kids the care that they immediately needed as possible.
So I appreciate the Lions have had such a footprint in vision screening in a variety of states. I think you've articulated in the past that there are different screening programs, but KidSight USA, or now it's Lions KidSight, the footprint is in many, many states across the country, as I understand it.
There's Lions KidSight vision screening done in every state and most of the Caribbean islands that are associated with Lions and Puerto Rico and our territories. Some of those programs are still, I'll say, loosely organized, and some of the programs are very well organized with a board structure and so on. One of my goals is to have everyone well organized with a board structure and being sure that everyone is trained to the highest level and understands all the best practices. And we're working towards that goal, and we're making progress every year towards increasing our effectiveness in that.
And how does an individual location tap into that? I mean, their local Lions Club certainly is one avenue of approach, but many states have robust vision screening programs. I think some, many are state mandated, but where it happens through the school or through the primary care, where in a given society or state or county do you, through KidSight, find your role versus the roles of primary care and school?
That varies dramatically by community and somewhat by state. So we try to have Lions reach out to schools, daycare centers, Head Start programs, nursery schools, and so on to tell people and the administrators the benefits of children's vision screening, why it's so important to have young people who have risk factors or potential risk factors for vision problems to be detected early, show them the data, show them what we do, show them how easy it is with the devices we have today, and then start screening. I'll be honest, there are some schools that really just want to totally rely on chart screening, Snellen chart screening, and then other schools do a combination, which I think is the best way, frankly. And then other schools just do electronic photo screening. So it depends. A lot of times, if some of the, say, K through 12 schools are not quite ready to accept children's vision screening beyond Snellen chart, we do the nursery schools, the Head Starts, and the daycare centers. Head Starts really like our program because they have to have their screenings done within the first 45 days of when their school starts. And as you know, our screening program is very quick and easy and fast and quite frankly, very accurate.
And for the listeners who maybe aren't familiar with KidSight, can you speak to the logistics? Like, who are the children you're screening? What are the age ranges? How many programs do you have in terms of teams? Is it in every state? Can you walk us through the logistics?
Yeah, so it is in every state to varying degrees. And like I said, some are more organized, some aren't. The logistics are that we promote doing screening, concentrating on 6 months to 6 years of age, because we really want to catch those kids who have risk factors for amblyopia, or as the public calls it, lazy eye. But then we say that we will screen kids up through grade 12. And I always emphasize the word grade 12 because there might be a special needs class where there are kids a little bit older than the average 12th grader that we're still screening. And the reason that we like to advocate screening some of the older kids is while amblyopia is not as dramatic at that age because it's either been treated or not treated, kids still become nearsighted and kids still have significant farsighted or astigmatism that's interfering with their academic ability. So we still like to catch those. I don't think it's a big secret today that almost everyone in the eye care field is talking about the epidemic of myopia, especially since we're all doing all our screen time and the increase in the prevalence of myopia. I've read articles from virtually every continent the last couple of years that talk about that. So screening kids that are 12, 13, 14 years old is still important, but we like to concentrate on the younger kids.
There are things about KidSight that I'm aware of, but I want to make sure you communicate to the listeners. Number one, the importance or the tools you guys embrace regarding the automated vision screening technologies. So what would you advise in places that are doing their own screening as they look at these automated technologies? And number two, what would you advise, or how can you frame KidSight's follow-up? So kids fail screening, what's there for failed screening? How is that approached? So two questions. One is automated technologies, and number two, the follow-up.
So the automated technologies, there are several instruments that are really good on the market today that provide basically an 80% sensitivity and a 95% specificity in our results, following the APOS guidelines for criteria for referral by age. So we recommend, if you're going to do electronic photo screening, to work with the schools and have the schools get permission to do the screening, either as a global permission or an individual permission per event. And the Lions can conduct the screening, and the Lions strictly say either pass or refer. They don't do any interpretation of the results, and they give those pass refer results to the school nurse and the school teacher. We like it because it's quick and cooperative children. It takes less than 30 seconds to do a screening. As you know, the child just needs to look at the center of the cameras, no matter what instrument it is. We need to look at the center of the camera for about a second for us to get a reading. And it finds refractive errors of all kinds, gaze deviation, and unequal pupil size in anechoria. And the young kids, we're particularly looking for anechometropia, which, as you know, one eye has a dramatically different prescription than the other eye. And then, again, the results, we like to recommend doing anonymous screening where none of the personal information is collected by the Lions. We just write pass or refer on a form and give it back to the school nurse and teacher. So HIPAA and FERPA and all those regulations are followed. Then we recommend for follow-up that the teacher and the school nurse do more than just send a letter home to the parents saying that those children that were identified as needing to be referred go to the eye doctor. What we're finding nationwide is that if that's all you do, that you're going to get somewhere around a 30% not referral rate, excuse me, a 30% rate of compliance on behalf of the parents in actually taking their child to the doc. So what we recommend then is that a month or so later, either the school nurse or the teacher or the administrator, if it's a daycare center or one of those agencies, to call the parents and say, did you get a chance to take Ed to the doc? Remember that we referred Ed last month. And if the parent says, no, I didn't get a chance yet, then we asked that administrator or teacher or school nurse to say, well, if you don't have a doc, here's a list of docs that might take your insurance. If you don't have money or can't afford it, you don't have insurance, most Lions clubs have a fund that will help you pay for that. If you don't have transportation, because maybe both parents are working, they can't take time off, and grandma doesn't drive or whatever, we can help pay for an Uber or some public transportation to get your child to the eye doctor or so on. You know what? I'll call you back in a month to see how you made out. And if the second month call is still a negative, we recommend maybe one other call, unless the parent says, don't call me. But we try to recommend that the administration of the agency in one way, shape, or form make up to 3 calls to the parents, encouraging them to go to the eye doctor. After 3 calls, most everyone agrees that, I hate to be blunt, but when I lecture on this around the country, I say you don't need a license to be a parent. And sometimes there are just parents that just aren't going to pay attention, and that's just,
Yep.
you have to learn to live with that sometimes. If we do those calls, however, our data seems to indicate generally that we can increase the compliance rate from 30%, give or take, up to about 75%, give or take, of parents who will follow through.
And can you speak to how often kids who are being screened actually, I don't know if you use the word fail, but where they are required or recommended to get further screen or further follow up? What's the
So
percentage?
our referral rate, and
Yeah.
the referral rate varies dramatically with demographics.
Okay.
So if you can imagine, I hate to say the word average demographic because there really isn't any, but if you can imagine an average demographic, on average, we're going to have about a 12% referral rate, give or take, sometimes maybe 15. However, if we do special demographics with special gene pools, for instance, if we're doing a school that has a very high Hispanic population, there's more astigmatism in the Hispanic population, so the referral rate might be 18 or 20%, and so on. The Asians, for instance, have more nearsightedness and more astigmatism. They may have a higher referral rate of 20% or so. If we do special needs kids is not unusual at all. If we do a school that concentrates on special needs kids, we have a 35% referral rate. So it varies a lot, but the average referral rate is going to be somewhere between 12 and 15%.
As a pediatric ophthalmologist, I just need to comment on the referral rate journey. There's such a balance between catching all the kids that need to come in and yet not overloading the clinics for the children that deserve and need the eye care with all the children that don't need to be there. One of the other plugs I'll say too is vision screening, like so many screening programs, is meant to catch disease in children or in other conditions, adults, that are asymptomatic. Mm-hmm. And most guidelines, including you brought up the American Association of Pediatric Ophthalmology and Strabismus, APOS, have guidelines for referring or individuals caring for children. And it generally would suggest in most organizations that if a child has a disease that could increase their risk for an eye condition, they warrant an eye exam. They shouldn't depend on screening. If they have a family history of a disease that puts them at risk, they should get an eye exam. If they have a medication they're on that could risk their eyes, they get an eye exam. But you go down through, and including is anyone that can't do screening, that are non-compliant, that have neurodevelopmental concerns, that have performance in schools. There's a understanding that children who don't seem to fit into the normal category of highly functioning should get an eye exam, and that's appropriate. So sometimes they'll comment on, and I'd like your thoughts on this, but you hear examples of a child, say, with autism, that vision screening didn't meet the needs that the child had and missed something. And I always like to remind the public that a child with autism or with developmental delay or other neurological concerns or couldn't finish the screening test, those all deserve comprehensive eye exams. It's only the children that pass everything and we don't have any concerns over that are truly the best kids for screening programs.
Yeah, I totally agree. I'm smiling because I get a lot of questions out in the public, and people know in our community know the work that Gail and I do, and somebody will come up to us at the grocery store and they'll say, I had a lazy eye when I was a kid. I wonder if you could screen my son. And I'll say, why are we screening you? You should go to the eye doctor.
Yep.
You don't need to rely on a Lions Club vision screening when you already know that there's a risk here. So just go to the eye doctor. And we recommend doctors who are good with kids and so on.
Yeah.
I
must admit, you probably get approached by many, many individuals, and you hear about phenomenal testimonies and appreciation of what the Lions do in the sphere. You travel the world, whether it's in Minnesota or India, to promote this. Can you share a testimony, a story, just memory or one or two that captures what drives you to keep doing this?
We were in Nicaragua before KidSight. We were in Nicaragua doing a vision care mission with Lions clubs, and we brought some low vision magnifiers with us as well as used eyeglasses and so on. And there was this one young girl who had Stargardt disease that started to lose her vision and had some education up to the point where she started to lose her vision. And then the local schools in that particular environment were not necessarily prepared to handle her condition. And all we did was give her a 2x hand magnifier. And I believe my wife worked with her and gave her this magnifier. And there were, I don't know, 100, 150 people in line waiting to see us at the time. And the girl went up and down the line. I could read, I could read, I could read. So that's kind of a cool story. Other times we would have someone who, I remember this also, we examined someone who was pretty highly nearsighted. And it's kind of a funny story in a way because we had a young student group with us, and we provided, and I forget the prescription, it was somewhere around -8 or -9 nearsighted on this one young man who was a teenager. And we put the glasses on him, and just about that time, one of our young female interns walked across and he just looked and looked, and I looked at him and I said, señorita, señorita, right? And he could see at a distance for the first time and enjoyed that.
Wonderful.
Yeah. Can we switch gears a little bit to advocacy? So I'm sure you have a lot of thoughts about this, but there are states that require vision screening before school, and then there are states that do not, right? So the laws are very different. So I am curious your thoughts, and specifically what you'd like to what you would like to be done, and what you would like to see kind of state to state, if we could be better.
Yeah, obviously, I believe that all states should have vision screening standards for kids, and all kids before they enter school should have a vision screening. For obvious reasons, 80% of learning is from vision. So if a child is having vision problems that are asymptomatic and mom and grandmom and their family just doesn't notice it, we put them in school, they're behind the 8 ball already, and they're having a hard time just keeping up with their school. So with their school work. So everyone should have some baseline vision screening. The methods of vision screening, I have a particular model in mind that some states follow. Hawaii does this in particular, where a child would be screened the same day with Snellen chart and electronic photo screening. So the child comes in and gets one or the other first. If they are referred by either of the tests, then it's a referral. If they pass either one of the tests, then they go through the rest of the color vision and some of the other things, and they get either the Snellen or the electronic photo screening that they didn't get in the beginning, and they either pass or refer. If they refer either one, it's a referral. And if they pass both of them, then that's fine, then they pass. And the reason I believe that it should be both electronic photo screening and Snellen chart is twofold. Number one, I think every student needs to have a base Snellen chart reading before they enter school. And the perfect example I like to use with some of my colleagues is that if someone goes in and no one knows what their baseline vision is, and 2 years later they get hit in the eye with a baseball and the vision is 20/200, we don't know where they started. We don't have a baseline record of what that vision was first. So just from a medical legal point of view, you need to have that. But number two, I believe there are some conditions that electronic photo screening doesn't detect. And there are some conditions that Snellen charts don't detect or not very good at detecting. So having both of those lets us cover as many bases as we can, knowing that it's still a screening, not a comprehensive eye exam with a dilated pupil, which obviously is the gold standard. So I don't know if that directly answers your question.
I mean,
That's what
yeah, I mean, it gives
for.
us all motivation to do more lobbying, right? And be advocates for this, because it sounds like not every state is doing that.
And I think, I'm sorry,
Go ahead.
I think one of the reasons is that when you look at the school nurses and you look at the school administrators, even on the state level, they're overwhelmed. They have so many things they need to deal with. From a school nurse point of view, they need to look for head lice. They need to look for straight backs. They need to check the teeth. They need to check the eyes. They need to, be sure that the diabetic kids get their medicine and their snacks during the day. Oh, by the way, another kid comes in with a skinned knee, and I need to take care of that. The jobs are overwhelming, and so when we start asking the administrators and the boots on the ground, school nurses, to do more or do something different, it's really challenging for them. And I think as advocates and as eye doctors who obviously have a bias, we need to present our bias and present our advocacy in a way that recognizes the hard work that they're doing, recognizes the challenges that they're doing, and then, quite frankly, step up to the plate and help them. My wife and I go to the schools and do the electronic photo screening. We don't just dump it on them and ask them to do it. And we're available to them as a resource for anything that they may want and so on. I think it has to be a two-way street if we're going to be successful.
Let me circle back to something you commented on, and I agree with you. For diagnosing disease, the comprehensive eye exam with a dilated pupil is kind of considered standard of care. The challenge in society is that we have so many children that don't have disease, it's hard to know how to administer a certain standard of care. I know that there are children's stories that are testified that they were missed in vision screening, but no different than a family with a child with scoliosis suggesting every child should see the orthopedic surgeon before school, or a child with a heart defect says every child needs to see a cardiologist before school. It gets into the same realm when you've had a child with a vision concern. You might suggest that every child needs a comprehensive eye exam before school. So I'd like to get your thoughts, because you're an expert in this field, that there is a professional and an advocacy journey and push-pull between the role of vision screening and the role of comprehensive eye exams. And obviously the Lions KidSight has embraced the vision screening side of that. Share what's your table talk about that issue or about that balance?
Table talk, I have this conversation a lot with people, and I will be the first to say that in an ideal world, under absolutely 100% ideal conditions, you wouldn't need me or Lions KidSight or Children's Vision Screening, because every child would have a comprehensive eye exam with a dilated pupil as a neonate, and then whatever the appropriate interval for that individual is throughout their life. Without a shadow of a doubt, that's the gold standard in my mind. The problem with that is that, number one, we don't have enough docs, and number two, we don't have enough money. Because even if insurance pays for it, someone pays for it. The money and resources have to come from something. So when I say that vision screening has an 80% sensitivity and a 95% specificity, I understand that means we miss 20% of the kids that we're supposed to catch. It's a screening, it's not a comprehensive eye exam. I also understand that with a 95% specificity, that 95% of the kids that we do refer need care. We only have a 5% over referral rate. So I like to present vision screening as a public health process that does its best to identify most of the kids, most of the time, that have risk factors that need to be addressed. Knowing that there is a certain amount of over referral, under referrals. But if we do every child every time for the comprehensive eye exam with a dilated pupil, then we're going to have a 90% over referral rate, because on average, anywhere between 5 and 10% of the kids are going to be diagnosed and need to have some treatment. And that's fine, but a 90% over referral rate is not a good use of medical resources and so on. So we don't live in an ideal world. So therefore, I believe that vision screening done properly, following good standards of care, following all the APOS guidelines that we do, will give us, and also screening every year, will give us the best opportunity to identify most of the kids who need to be treated most of the time. And that sounds a little amorphous, but I think it's the economic and staff power, if you will, reality of the situation.
Well said. Well, I just want to say thank you for this journey. Okay, you were going to say something else.
You mentioned something before that maybe I neglected to say when we were talking about the protocols for screening. One of the things we teach our Lions and really hammer on is that if you're doing a screening and you don't get a reading and you look at it and you say, well, everything looks good, job was cooperative, I did right, picture looks good, and the machine comes back and says, can't get a reading or measurement incomplete, do it again. You can still get it, do it again. But if you get 3 times where you're just not getting a reading, that's an automatic referral, because there's something going on that stops the device from getting you a screening. Now, if you back it up with a Snellen, maybe the Snellen would indicate an issue, but in our standards of care, if you try 3 times and don't get a valid reading, then that's an automatic referral. We find a lot of retinoblastomas that way each year. I would say 20 to 25 a year I hear about, just because they can't get a reading.
Yeah. This is my final question, because I think we're running out of time. For the optometrists and the ophthalmologists who are listening, I guess, what are some parting words from you, something that you want to make sure that they are in tune with, or advice for those who are starting their own careers as eye providers, but also in their careers of service?
Well, what I'm about to say, I would say, is appropriate to anyone in our healthcare field. And that is that whether you're employed by a group, or whether you're employed in a private practice, or whatever your mode of practice is, everything that you have comes from the people in your community. Whether they pay you directly in fees, or whether your insurance company pays your salaries through your group, the money that supports you and pays for your house, your clothes, your car, your vacations, everything you have comes from the people. And therefore, we consider ourselves rather lucky people to be in the position that we're in. And we don't have to worry about many of the things that our friends and neighbors have to worry about. So we firmly believe that we owe it to give back just a little of what they gave to us. Because if it weren't for the people in the community, we wouldn't have the things that we have.
Mm-hmm.
So giving back through Lions clubs, giving back through your church, giving back through whatever other community service venue you choose, I think is very important. We just happen to choose our profession and eye care and children's vision screening as our way of giving back. But health professionals, we're in this profession to help people. That doesn't mean we need to restrict that just to what we do every day in our office.
Yeah. Thank you for sharing your passion with us.
Well, on behalf of 2 ophthalmologists here at Mayo that care for children, on behalf of 2 co-Lions with you that serve our communities. I just want to say thank you for sharing your passion, your history, and your vision for how we serve children.
Thank you very much. I've really enjoyed this. It's great to get to meet you. And maybe we can get together on a Lions Club or maybe even a mission together sometime.
Thank you so much.
Thank you.
Thank you very much.
You can find all episodes of the Mayo Clinic Ophthalmology podcast on our website, YouTube, or on most podcast platforms.
Thank you for listening, and we definitely look forward to sharing more on our next podcast.